Thank you, Roxana. That was a great talk, Dipti, but as I said, I was so worried about this debate that I didn't even know it was a debate. Okay, I just looked at my responsibilities. It looked like a talk. So now I'm going to show you my slides that were prepared just for a talk, but now I'm going to turn them into debate slides. Okay? All right, my disclosures. So I certainly agree with Dipti that not all high-risk and complex patients are created equal. And when I think of the CHIP patient, the patient that needs or potentially needs mechanical circulatory support, it's a patient with multiple comorbidities, often surgical turn-down patients who, yes, has complex coronary anatomy and hemodynamic compromise. I'm always surprised when I'm seeing Impella used in patients with ejection fraction of 50%. So those are really the high-risk patients. So let's look at how we're doing with PCI in these high-risk patients. So, Dipti showed us the data from a single-center retrospective study. I think the best high-risk study that's recent, this is a multi-center prospective study, is the Optimum Registry. And this was PCI in 726 patients who were turned down for CABG at 21 of the best United States PCI hospitals. And you can see what cases are being done now. The mean age is 70 years, more than half have diabetes. The mean LVEF was only 42.6%. Now, these were not all classic CHIP patients. You can see the reasons for surgical ineligibility here. You look at these patients, though, they have very complex coronary artery disease. They have a mean syntax score of 32.4. They have frequent left main disease, CTO, require atherectomy, and hemodynamic support was only used in a quarter of the patients. So how do we do in these patients at the best hospitals in the United States? Well, the first thing is we don't do a great job revascularizing them. We turn the syntax score of 32.4 into 15.0. We still leave a lot of patients with a lot of residual coronary artery disease. We only get complete revascularization in about 1 in 9 patients. And we only get reasonably complete revascularization, a residual syntax score of less than or equal to 8 in about 1/3 of the patients. So we're rushing through these patients and we're not doing a great job completely revascularizing them. And how do we do in terms of survival? Horrible. These are the best hospitals in the United States. 3% in-hospital mortality, 6% 30-day mortality, and 12% 6-month mortality. And if you look at how this is compared to what was predicted, it's actually similar to what was predicted by the STS and Euro scores. The surgeons thought it was going to be worse than that. They thought it would be a 10% 30-day mortality, but our great NCDR CAT PCI registry thought it would be 4 times less mortality. So we need help in these types of patients, and we're not frequently using hemodynamic support. But there is a good reason to revascularize these patients, because even if we're not saving lives, and we may be because there's not a control population, they certainly feel better. They have better Seattle Angina Questionnaire scores, they have less heart failure, they're doing well if we can just keep them alive. So the potential benefits for mechanical circulatory support is that, one, we get them through the procedure. We have improved early outcomes because of less procedural complications. But I think perhaps more importantly, by not creating a firestorm situation where you can take your time in the cath lab, you can use physiologic lesion assessment, you can use intravascular imaging, you can treat the right lesions, you can get optimal stent results, and you can have a higher rate of complete revascularization. And this should lead to not only lower rates of stent thrombosis and restenosis, but also better recovery of poor left ventricular function, leading overall to lower MACE, heart failure, arrhythmias, all cardiovascular hospitalizations, and better quality of life. There's also some data that the renal blood flow effects of potent mechanical circulatory support can lead to decreased acute kidney injury and perhaps preservation of long-term renal function. But all this is, at this point, hypothetical. And it really depends on what hemodynamic support device you use and what your goals of. You want to support the systemic circulation, you want to unload the ventricle, and you want to ideally increase coronary perfusion. And the only one that really does that is Impella. And of course, the CP is very different than the 2.5 device in that regard. So you saw the results, at least the partial results, from the BSIS-1 trial, and these are truly CHIP patients. This was more than a decade ago. It's 300 patients in the UK with an EF of less than 30% and extensive coronary disease, randomized to balloon pump versus control. And there was no overall difference in hospital MACE, which was the primary endpoint of the trial. Although the patients became unstable in a high proportion of patients in the control arm, such that 12% of the patients had to cross over and receive an unplanned balloon pump. But what DIPTY didn't show you is that when you follow these patients out to 5 years, the patients who had balloon pump support during these CHIP procedures had lower mortality. Lower mortality, p-value 0.039. Now, that's hypothesis generating. It came from a secondary endpoint of a negative trial, but keep that in mind as we now look at the PROTECT II trial. Now we're starting to compare less potent circulatory support with balloon pumps versus more potent circulatory support with the Impella 2.5 device. And now we see in the PROTECT II randomized trial that the 90-day outcomes seem to be improved with Impella. Borderline by intention to treat, but significant in the per protocol population. And yes, this trial was probably in the worst mistake ever by a DSMB, stopped early for futility. And it probably would have been wildly positive if it was allowed to go to completion, as you can see, because they weren't looking at the 90-day outcomes, they were only looking at the 30-day outcomes. Once again, you see with time, the curves are spreading. More potent mechanical circulatory support, better long-term outcomes, not just early outcomes. When these results were re-adjudicated by George Dangus using a more contemporary MACE definition, now you see the curves start to spread early and are significant by 90 days, favoring Impella 2.5. But we don't use 2.5 anymore. Now we have even more potent circulatory support. We have the CP device. And the PROTECT III post-approval US Impella registry looking at the CP device in high-risk PCI patients was looked at, and patients who met PROTECT II criteria were compared to the Impella 2.5 treated patients from PROTECT II. And you can see there tended to be lower rates of in-hospital death. The MI rates were much, much lower, but I think that is an artifact of not having similar biomarkers assessed. So ignore the MI, that's not fair. But there was less repeat revascularization, tended to be less vascular complications despite a larger device being used because of better vascular access, much less bleeding, similar to lower acute kidney injury, and much less hypotension and ventricular arrhythmias and need for CPR during the procedure with the more potent CP device. And now if we look at the long-term outcomes of CP compared to 2.5, once again, let's ignore the first few days because that's dominated by this unfair MI comparison. Let's just look from 3 days to 90 days, and you're seeing more potent mechanical circulatory support. What happens again? The curves spread over time favoring MCS. So, that being said, MCS use in the United States is almost non-existent, okay? It's some unprotected left main patients, some atherectomy patients, but it's less than 1% of cases, although now it's almost all Impella. And that's because the guidelines, as you saw in the United States, give it only a Class 2B recommendation because of the absence of definitive evidence. And in fact, the European guidelines have never mentioned the concept of mechanical circulatory support during elective high-risk PCI. In any guideline ever, it's never even been mentioned that you should consider it. So, as DIPTY closed and as I'll close, we're trying really, really hard to generate definitive data. And in the PROTECT IV trial, we're randomizing 1,252 true CHIP patients with either chronic or acute coronary syndromes, complex coronary disease, and a left ventricular ejection fraction proven by echo core lab to be less than or equal to 40%. And they're being randomized after turned down from surgery to as the most appropriate therapy, because they've all got multivessel disease, to the Impella CP or control, which can be either balloon pump or no balloon pump according to the site. And we have a lot of different tests that we're doing, serial echocardiography, multiple quality of life tests, et cetera. We're biomarkers, and we're following the patients through 36 months. Our hypothesis is, as I mentioned before, that By providing hemodynamic stability during high-risk complex PCI, Impella will facilitate improved stent optimization and more complete revascularization that will translate into improved early and late outcomes. And therefore, our primary endpoint is the composite rate of all-cause death, stroke, durable LVAD or heart transplant, MI, or any cardiovascularization through 3 years, not 90 days, Dipti, through 3 years. Okay, assessed when the last patient reaches 1 year follow-up. We also have multiple sub-studies, including an acute kidney and chronic kidney injury sub-study, right heart cath, viability sub-studies, which are going to be fascinating. But anyway, I totally agree with Dipti. We don't have evidence yet to say that you should routinely be doing MCS in high-risk patients, in every high-risk patient. And right now, you've got to be very selective because there will be an increased risk of vascular and bleeding complications. So now I'm talking like a doctor again, not just a debater. So you got to be selective today until we have strong data. But I'm happy to say that we've randomized 955 patients to date, actually 961 as of today. And so hopefully within a couple years, we'll have the PROTECT 4 data, and that will tell us how to move forward. Thanks very much.
That was the